So let's just talk a little bit about, how, what else we would tell a patient, if we were to select Radium-223 as the treatment choice for that particular moment in time, specifically for this patient. So my discussion usually goes as to why I'm picking or selecting Radium-223. I obviously educate the patient as to what options we have. It's very hard to talk to patients and tell them you have 20 options. So I usually tell what I describe the buckets of treatment. And I explain to the patient that the goal is to actually get exposed to all the treatments that have shown to be life prolonging, meaning that have led to survival improvement. And I explain to the patient why I would pick Radium-223 in that particular case. So as I alluded to earlier, I think it's very important to actually explain to the patient that this agent, works mechanistically in a different manner, again, through the bone microenvironment. And although the mechanism of action is not specifically, known, if you will, we do know it's an alpha emitter, so it's an alpha particle, right? It's like a radionuclide-based therapy. But these particles are big, they're thick, they have short penetrance. So basically what they do, they go to areas where there has been bone remodeling, if you will, and they compete in that space, and they sort of repair, if you will, all that, vicious cycle of osteoblasts, osteoclasts, and so on. It is also important to remember that alpha emitters do have and do impact DNA, and they actually break DNA in the double-strand DNA, contrary to the beta emitters, for instance, that are just single-strand DNA breaks. I also tell the patients that talk about, obviously, the survival improvement. I talk to the patients as to why fixating on the PSA during the next 4 to 6 months of Radium-223 therapy, may not be the most important feature of our follow-up. As I alluded earlier, I like to actually tell the patients that although in Alzheimer's scans were not mandated, I like to continue getting the scans. And although I can be criticized for saying scans, bone scans and CT scans, the reality of it is we don't know what the impact of alpha emitters in the uptake of technetium for that matter. I just do it, to be honest with you guys, because I feel that I don't want to lose a patient who is progressing rapidly without any symptoms or without any drastic PSA changes, specifically really looking for visceral changes. I tell my patients that it is very important for them to know that the treatment roughly is going to be 4 to 6 months. I think in my personal practice, I think most patients can get 4 to 6 cycles of therapy. In fact, if you look at actually the median number of cycles given in Alzheimer's was 6, and the expanded access was around between 4 and 6. So I really tell the patients that I'm going to be the quarterback of their care, that I'm going to be using, either radiation oncology or the nuclear medicine team to actually give the Radium-223, which is a pretty straightforward approach. They go to, in this case, you go to nuclear medicine, you get an IV push over 5 minutes of the infusion, but it's very important for us to work cohesively as a team, because I like to pay attention to blood counts. Obviously, every month, every time the patient is coming to get Radium-223, I'll check the hemoglobin, the platelets, But more important than that is also to recognize the fact that there are other things outside PSA that one can pay attention to. Alkaline phosphatase, which is either making the liver or making the bone, is a very good marker, in my opinion, for bone disease. When you see it elevated. So traditionally, when 80% of men with prostate cancer will develop bone metastases, and a significant proportion of those patients will have an elevated alkaline phosphatase, which means they have active disease in the bones, right? So if you were to have a patient such as that, right, you could, in fact, pay attention to their alkaline phosphatase changes during the time where you're treating them with Radium-223, because I would bet that if you look at the data and clinically speaking, almost half of patients who are responding to Radium-223 will have declines in their alkaline phosphatase levels if, in fact, they had it elevated from the beginning, right? And in fact, if you look at the correlation between alkaline phosphatase decline and PSA declines, at least I published that when I was a fellow in San Francisco, you can see there is a natural parallel, association between the decline of alkaline phosphatase and the declines in PSA. And sometimes you see also the opposite, that when alkaline phosphatase is rising, your PSA is also rising. In Alzheimer's, approximately 30% of patients or so have alkaline phosphatase declines. I think it's a good way to also help navigate the lack of PSA reduction. So you have a patient who feels better, is not having symptomatic progression. Your scans are stable, but your PSA is creeping up a little bit, if you will. So you can assure the patient that you're not symptomatic, your scans are stable. Yes, your PSA is going up a little, but look at your alkaline phosphatase. Your alkaline phosphatase is the opposite, it's coming down, and the fact that it's coming down would represent, at least in my opinion, treatment effect. Now, it's also important to recognize that having a baseline hemoglobin of a less than 10.5, it will be important before you start Radium-223. You pay attention to it in every subsequent infusion, but it's not it's a mandatory test that you have to actually do on a subsequent basis. I think it's important for us clinically to do it, so you're not seeing a patient developing anemia, especially if the patient has been heavily pretreated in the past. The incidence of really thrombocytopenia and or neutropenia, in my opinion, is low. As I alluded to you in the ALSYMCA data, was around 1 to 2% in the chemotherapy naive patient population. I like to do it again because I don't want to actually have any issues with thrombocytopenia or neutropenia in those patients. It's low likelihood, but it's still something that I like to pay attention to. There's some, when you look at actually, a concern from patients, especially male patients who are married, our grandfathers, our fathers, there's always a connotation of radionuclide-based therapy or radiopharmaceuticals, right? It's the thought that, am I going to be radioactive when I get home after I start my treatments? The reality of it is the K factor for Radium-223, if you look at actually the biodistribution, and I'm certainly not an expert in that data, you can see, or at least in the biology of that data, you can see that within 4 hours, almost 95, if not greater than that, of the material has been actually already been out of the system, usually goes through feces, and by the next day, it's pretty much gone out of our body because it concentrates really in the bone. There's some element of maybe GI side effects, specifically sometimes soft stools. I really haven't seen that in my practice, and I use quite a bit of Radium-223, not only in the trials, but also after FDA registration. I haven't seen it. I think the most common cause, at least in my practice, of why people actually stop Radium-223 is because they progress. And very few patients, a few percentage of patients, perhaps because they have some issues with low counts. I personally like to use Radium-223 earlier rather than later. But again, it needs the right patient phenotype, someone who's not rapidly progressing. If you have actually concerns for pain control, right? So if you have someone who's really crippled by pain because of prostate cancer in the bones, it is very hard for you to suggest, at least in my practice, to suggest to use Radium-223 because time to pain control may not be a week. Whereas with docetaxel, with cytotoxic therapy, you can control pain quite drastically and quite rapidly, within the first week of therapy, if in fact the therapy is working. So I think they may be better for those patients to actually concentrate quickly in controlling the disease, controlling the symptoms. And once you're done with chemo, you can decide what to do with Radium-223. But certainly, in the context of those symptomatic patients, I prefer to start, especially who need rapid pain control, I prefer to start on cytotoxic-based chemotherapy. It is also important to remind the group that the use of radiation therapy for castration-resistant disease. So there are patients who may have isolated bone progression, meaning that you may be able to actually use palliative radiation therapy to control bone pain. If you look at ALSYMCA, actually radiation therapy was not excluded. Prior radiation therapy for pain control was not excluded in the trial. In fact, it was part of what it was allowed as best supportive of care, right? So I don't do that, and I'll explain why in a second. I think that if you have someone who has isolated pain progression, you could actually consider giving that patient or working with your radiation oncologist to give that patient a little bit of radiation therapy for palliative purposes, and then move on to Radium-223. That would be perfectly reasonable because radiation therapy was allowed within that ALSYMCA data. I would argue that for those patients who may actually have still some degree of bone pain, if you feel they're not symptomatically progressing on Radium-223, you could actually consider, giving them radiation therapy while they are on Radium-223. I don't tend to do that much, I may say, because I want to make sure that if I'm going to do radiation quickly, I'll do it before I start treatment. If you need radiation therapy for palliative intent during therapy, to me, that's an element of progression unless I was preceding, your treatment. So if someone is on oral therapy, on chemotherapy, or radium or CPT, and you're progressing symptomatically, and you are in need of palliative radiation therapy, to me, that's an element of progression, because that's how I define progressive disease in the castration-resistant setting. Lastly, perhaps, is for that point of counseling the patient, you can tell the patient that there is no need for the patient to actually be concerned about that. Actually, patients can go back and take care of the grandchildren. I mean, there's some universal precautions that we actually counsel the patient with. We have a team of people that will sit with the patient, educate the patient, provide the typical things that we do for this class of agents as to what to do, what not to do, but really they're not beta emitters. So in that context, I don't think that that's going to be a big issue for treatment selection, and certainly some reluctance from the patient to receive this treatment.